What is in medical interpreting? Medio IGC 101, Unit 5. So I'm Dr. Isabel Souza. I'll be presenting this unit as well. We can move on to the next slide. We're going to be talking right now about possible errors, and that it's an imperative that we know the different types of errors we can come across. So interpreting medical information for patients has become an area where healthcare providers risk major lawsuits from medical errors traced to inadequate translation. There's a wonderful quote from Glenn Flores, a doctor in Massachusetts, that stated, interpreter errors could be previously unrecognized, interpreter errors could be a previously unrecognized root cause of medical errors. And he stated this in the Healthcare Risk Management publication, and it comes from a study that the Joint Commission did. The Joint Commission is an organization that accredits hospitals across the US and also internationally. And they started looking at what leads to a medical error. And the root cause is that first error that, basically becomes a chain of errors that ends up, causing the patient harm in some way. And more often than not, the issues had to do with communication. So sometimes we didn't recognize that when a doctor orders the wrong test, it's because he understood something wrongly, and that caused him to order the wrong test. And when you compound that, if that can happen with English to English speakers, imagine when you have different languages and third parties, such as the interpreter, that could certainly happen. So there was a study done in 2003. It was done back at Boston City Hospital. And what Dr. Flores saw is that most of the linguistic interpreting errors, remember I mentioned the linguistic barriers? Well, most of the linguistic errors of the study had to do with these categories below. Omission, leaving out meaning or information, that was 52% of the errors. That means that half the time the error may be related to simply not hearing something or not understanding it and omitting it. We also call this glossing over. And glossing is dangerous because when you gloss, you're basically determining yourself what is important and what isn't. And remember, if we're going to interpret accurately and completely, we wouldn't be able to do that. 8% of the errors had to do with addition or adding meaning. That happens when we're not listening actively, and perhaps we listen something that wasn't stated. And that can happen when we inadvertently add our own, understanding to it. So adding is also an error. Substitution, using a different meaning. You could also call this wrong interpretation. So interpreting, gallbladder as bladder. Now, that's a definite substitution, and it could have a health care impact, 13%. 10% editorializing, providing own viewpoint. Editorializing typically, has to do with adding, but it could be omitting as well. It could be distorting. And it's basically injecting your own way of understanding versus what the individual actually meant. And then there's false fluency, using terminology that simply doesn't exist in the target language. 16% of that would be false fluency. So if you don't understand something, if you're not sure that term exists in the other language, we have to later research it. We have to look for ways to avoid these. And as you do your practice interpreting, you will see that these errors are inevitable. However, they can be minimized greatly by self-evaluation, by active listening, by really at the same time that we're interpreting, we can be evaluating the interpretation in order to catch any of these issues. And when we do catch them, we go into third person and we state the interpreter needs to correct something, and then go ahead and do the correction. So now that we've seen all these possible errors, let's go to the next slide. And now we're going to look at some other categories that are non-linguistic. For example, not requesting a clarification when needed. Why is that an error? Because that error will cause you to gloss over something, or to editorialize, or to distort a meaning. Not addressing the environmental factors that affect interpretation. If you don't address the fact that you cannot hear one of the parties adequately, your interpretation will suffer and the communication will suffer. So these are errors that we make by assuming that we can't correct the issue. If there is so much noise, background noise, that you cannot interpret correctly, you will have to deal with it. And maybe all parties will need to move to another place. But otherwise, you will be the one doing a suboptimal interpretation, and it's going to be on you. It's going to be looked at as your failure, not other people's failure. You can't say and use the environment as an excuse for bad interpretation. That is one of our responsibilities, as we said in the last unit. Not reading verbal cues, nonverbal cues from providers or patients. We need to be able to read all the communication that's being provided, and not all of it is verbal. Much of it is nonverbal. And it's also in the tone and the manner, hesitations, everything really impacts the meaning. So if we're going to interpret the meaning accurately, we need to, look at all the clues for that communication. Intercultural interpreting errors. Assuming to know what the patient thinks. Just because we have a familiarity with the patient's culture, that doesn't mean our culture is exactly the same as the patient, because culture is a very individual thing. Every single person has their own cultural makeup. So not requesting confirmation from either party before any intervention would be a mistake and could cause you to actually assume something wrongly, give an explanation that is not the case. So, these are errors as well. Not having the appropriate language to explain a cultural issue clearly. So as you gain experience, you're going to know the types of situations, and you should have the phraseology, the language to explain any issue in a very succinct yet clear way. Your explanation cannot be so convoluted that people are having a hard time understanding the concept. So, that's why our own communication skills plays a role as well in our work. Now let's go to the next slide. So there are many regulatory standards, and the left column really deals with the US specifically. LEP stands for Limited English Proficient. So we're talking about, patients who speak spoken languages. The Title VI of Civil Rights Act of 1964 is very important because it was the law that established any discrimination based on gender, age, and also national origin to be against the law. So there was a particular case that created a precedent showing that anything that is against national origin can be construed as discrimination. So not serving a patient in their language can be considered a discriminatory act. And that is why so many laws do require interpreters to be present. The 2000 OCR's Guidance Memorandum, OCR stands for the Office of Civil Rights, was a very important document. I actually highly recommend that you all look it up and download it, take a look at it. And it really gives clear definitions of why it's important to, how we can, as organizations, not discriminate. ADA, the American with Disabilities Act, that is a very important national law in the US that really has become the underpinning or the foundation of all of the linguistic needs of deaf and hard of hearing individuals, whether they're patients or providers. A deaf provider will also require an interpreter at his side at all times, although the majority of cases we're interpreting for patients. The Joint Commission, I mentioned, they're an organization that accredits hospitals and basically is mostly focused on patient safety and all the standards of care that uphold patient safety. And class standards. CLASS stands for Culturally and Linguistically Appropriate Services. These standards were developed by the Department of Health and Human Services. They were created in 2001 and they were later revised in 2010. And they give very specific guidance for healthcare organizations on what to do and how to provide language access. And they talk about some of the things on the right that I'll explain. These and other regulatory entities require that a qualified interpreter be offered to the patient free of charge. So all of these directives, they always talk about working with a qualified interpreter. And they qualify an interpreter, and we'll do that in the last slide, versus, an individual who is assisting with the communication, which is not really a qualified interpreter. They all state that we cannot rely on a family member, especially a minor, unless it's a complete emergency. And nowadays with remote interpreting, it's hard to justify relying on anyone who's not a competent and qualified interpreter. They all state that we cannot ask a patient to bring their own interpreter. That's very important as well. So even if a patient shows up with a friend who is willing to interpret, healthcare organizations will tell that patient that they have a right to an interpreter, a qualified interpreter, and typically that interpreter will be called. So let's go to the next. Let's move on. Okay, let's continue talking a little bit about these regulatory standards. There are benchmarks that have been created to really establish, well, how can we keep the language access of so many different languages? The reality is that in the US, you have over 200 languages being spoken. So it's very difficult for any organization to meet the needs of all languages. So there are certain benchmarks, and I'm going to read them out here. So the LAP population would, of 10% or 3,000, whichever is less, must be provided with both interpreters and written translation of all documents. So here it's establishing that if you have 10% of a Cambodian or Haitian or Somali population in your county, or 3,000 individuals, whichever is less, you must provide them with interpreters and written translations of all documents. Now, there's another benchmark. So if the population is, the LEP population is 5% or 1,000, whichever is less, you will need to provide interpreters and written translation of vital documents. These vital documents are typically consent forms, discharge directions, or any important surgery preparation instructions, documents of that nature, or a health power of attorney. Those would have to be translated, but brochures and other documents wouldn't be considered vital. And then the last category is LDP population of 60 people or less. You would have to provide interpreters and written notice of availability of site translation. So in this case, each case the level goes down. Now, this is all about LEPs, or those that don't speak the local language, but if it's sign language, they go by the ADA benchmarks, and any deaf or hard of hearing individual will be provided with an interpreter at all times that are needed. That is the benchmark. So let's move on. The impact on services. Given that so many people in our country speak another language, you can either pay a little up front or you can pay a lot after you have medical errors. So this is an important quote because it really talks about the liability factor. And I can only give you one example. I happen to live in Florida now, and Florida happens to have the case that was the largest legal case in the US related to a medical error that actually was caused due to a bad or erroneous interpretation. So it's the case of Willie Ramirez. There's a great book written on the topic. You can look it up on Google. And Willie Ramirez was 18 years old, and he got incredibly sick, ended up in the hospital, and providers relayed on family members to communicate. And family members use the term intoxicated, and they use the wrong term because the provider had a different idea of what was going on. And because of the medical error and the lack of attention given to his case, he was basically considered intoxicated, as in drugged or some foreign substance, when actually he was having an intoxication. So very different. So unfortunately, Mr. Ramirez, at a young age of 18, became a quadriplegic. He didn't die, but his life certainly was changed forever. And the family was awarded a $70 million compensation. So it will never bring his legs back, and it will never make his life the same. But it comes to show that liability is very present when qualified interpreters are not part of the communication. So let's go to the next slide. So our impact is quite great. The benefits of working with qualified medical interpreters. So first of all, we reduce clinical errors due to miscommunication. Even if someone speaks broken English and says, oh, I don't need an interpreter, I'll be fine. Oftentimes providers want the interpreter present so that they can prevent any error and any liability related to the patient not understanding. And we have to realize that even when a patient doesn't want an interpreter, it doesn't mean the provider doesn't want that interpreter to be there. So if either party wants an interpreter, we remain in a session. It improves patient and provider satisfaction. And there have been countless studies done of this, but obviously providers find that it's easier to communicate with patients and they feel more satisfied, but patients are much more satisfied that they can communicate because they feel the burden even more than the provider. Improved patient compliance. Now that's a big one because that directly correlates to healthcare outcomes. How can a patient comply with something they can't understand or that they don't understand well. So again, the communication and the ability of both parties to understand each other is crucial for so many consequences. So another one is the improved patient-provider rapport. If a professional interpreter is doing their job right, definitely the rapport of the patient and the provider will be improved. And they will feel like they can communicate even though they can't. But they will communicate. It's simply that they rely on a third party, but they will communicate and they will come to understand each other as if they spoke each other's language. Compliance with the law, that's a benefit. That's a big one. And oftentimes we have to remind folks that we're not doing a favor, we're actually following statutes and we're following the law. Improved standard of care for vulnerable populations. Certainly interpreters will improve the session, but by doing that, we're actually improving the care of all of those patients that have difficulty communicating themselves. So that's very important. So let's move on. Qualifications of a qualified medical interpreter. So a qualified interpreter typically is trained and tested. But now with certification, we're hoping that more of them get tested through certification. What's the difference? Well, there are many national organizations and state organizations that test interpreters, but their test is only valid for their organization. So when an interpreter goes elsewhere to another healthcare facility, that healthcare facility might have another test to do to see if that interpreter can interpret well. And, you know, it's not a great thing to be constantly questioned on your abilities if you've been trained, but you haven't been tested by an organization. With certification has changed that because certification is national. It's done by a party that is, you know, a body that is trained and fit for that particular purpose, whereas most healthcare organizations aren't necessarily experts at testing. Certification bodies are. So once you're certified, an interpreter will not have to be tested in different places. So, you know, they're obviously fully bilingual individuals trained to interpret medical information accurately in the consecutive and simultaneous modes. There are situations where we need to go simultaneous. They will have the language proficiency of at least advanced mid-level or higher in both languages, the source language and the target language, also called working languages. They'll be knowledgeable of medical terminology in a variety of specialties in all their working languages. And that's important. Many nurses will say, oh, I'm bilingual. But then when you start asking them questions, they only studied, you know, nursing in one country. They don't have the terminology in the other language. So it's important we have the terminology in both languages. We're trained in ethics, standards of practice, protocols of interpreting. We're able to interpret in the consecutive and simultaneous modes. Those are what we called mode of interpreting. Consecutive, when we interpret after someone communicates, and simultaneously when we're interpreting at the same time with just a little lag of time. And we also need to be able to provide accurate site translation services. I've explained that site translation is when you read a document and then you interpret into the target language what is in the document as you're rereading it. Now that could be consecutively or simultaneously. So if you're doing a remote interpretation assignment, you might not have access to the document. So you might have to ask the provider to read a sentence and then you interpret. And then the provider reads another sentence and then you interpret. And that might be how you provide the site translation service in a consecutive mode. If you're present, you might actually as you read the document, you would be interpreting. You have to have the ability to ensure confidentiality of patient information. You also have to have the ability to provide intercultural mediation when cultural issues affect the communication. You have to be able to seek clarification to ensure accurate communication. And have that, it does require a certain professional standing to be able to impose your needs so that you can do a good job. You will need to have the ability to ensure that the patient's language rights are upheld, and the ability to enhance or work towards improving the patient-provider therapeutic rapport. So a qualified interpreter will have these abilities. And this is not something that just because you speak two languages, you'll be able to do it. Most people that speak two languages, the best they can do is relay a message as best as they understood it. They're not trained in active listening. They're not trained in accuracy and prevention of errors and self-examination in different modes of interpreting and so forth and so forth. So it's important that we are able to explain our qualifications to anyone who might not know the difference, because frankly, to a monolingual, they can't really see all these things. They can only see us interpreting. So we'll discuss more about all of this in certification later, but this gives you a good overview of the main qualifications of interpreters. So we're going to end it at here, and I thank you very much for listening.